Do you know that veterinary doctors are the only doctors in the world who eat their patients? As one can see, these are the goat, cow, and buffaloes. These are all the patients of veterinary doctors. Now, coming to the pathogenesis of Tinea corporis, dermatophytes are hyphomycetes that can degrade keratin of the epidermal layer, and they grow within the dead superficial keratinized tissue, resulting in Tinea corporis. Pathogenesis is determined by the pathogen related factors and the host factors, which are the inherent host defense and the host immune response, and plus the environment have certain role. There is adherence of the fungal propagules to the formation of the hyphae that spread within the tissue. Fungal metabolites, enzymes, antigens, and the pathogenic factors diffuse through the epidermis, and that causes the reaction because of the dermatophytes. These are the erythema, vesicle formation, and pruritus. Geophilic and zoophilic dermatophytes produce more irritants and inflammation than the anthropophilic species. Now, here one can see the anthracoonidia of the fungal spores or fungal spores. These are going to have the adhesion with the skin layers, and that causes the germination, and this germination lead to the formation of the hyphae from this arthrocoonidia, and these hyphae, these grow, and just these are going to invade the epidermal layer, and then there is arthroconoidea formation again from these ripened and full-fledged hyphae. These are capable of producing arthroconoidea, and these arthroconoidea, like here, these are capable of growing and making the hyphae formation. Now, geophilic and zoophilic dermatophyte produce more irritant and inflammation than arthropophilic species. I have already told you, and lesions expand centrifugally, and active hyphal grow occur at periphery. These penetrate into the newly forming stratum corneum. Now, keratinocytes are activated and destroying the epidermal barrier. Now, innate and specific immune responses are initiated, and these involve the neutrophilic granulocytes, macrophages, antibodies, and T cells. Infection do not involve nail plates, hair follicles because of the effective defense mechanism and the steroid hormones which these structures like nail plates and hair follicles do have. So here one can see the disruption of the epidermal barrier, and then there is keratinocyte. These are going to react, and the certain transmitters and cytokines and interleukins, these are just mediators, are responsible for causing erythema and the other structure which are the characteristic of the Tinea corporis. So here one can see schematically that dermatophytes and spores from the soil, animal or man. These dermatophytes, they take origin from these things, and then these invade the keratin layers of the skin. So it involves skin, hair, and nail. And this skin abrasion this causes the skin abrasion, and so there is entry of the stratum corneum by these dermatophytes. These dermatophytes now release keratinase enzyme, which is capable of destroying the keratin layer of the skin, and then there is inflammatory reaction occurs, that is causing the lesion, the redness, the swelling, the heat, or loss of hair, the alopecia. These inflammatory reaction that just causes the movement away from the site of the infection, and then there is peripheral ring formation occur, and there is central healing with classical ring lesion. So that is the main pathogenesis of this Tinea corporis. Now, what are the complications of this disease? Fungal infection rarely spreads below surface of the skin to cause any serious illness, but it too occurs only in the weak immune system. People like HIV or the AIDS patient or the patients on immunosuppressive drugs. It is contagious, spreading elsewhere on the skin or to the other people as disseminated infection, dermatophyte tide reaction. It is an allergic rash at a distant site, away from that site where the lesions are there. It is caused by an inflammatory fungal infection. Secondary bacterial infection with Staph aureus is also very common in case of the children because they do scratch and invite the infection from the skin. Dermatophytes penetrate into the dermis sometime and they cause granulomatous inflammatory reactions, systemic immune reaction, and that is called now ID reactions. Dermatophyte infection produce either inflammatory or non-inflammatory lesion. Now, coming to the diagnosis, these are the 5 groups by which we are able to diagnose the or 5 parts. Number 1 is history and clinical examination. Number 2 is wet mount preparation. Number 3 is potassium hydroxide or KOH preparation. Number 4 is fungus culture, and number 5 is skin biopsy. First, we are going to discuss history and clinical examination. Clinical information like site, appearance of the lesion, geographical location is important. Travel history, race of the patient, or animal contact is also important. Classical lesion on specific sites show erythema, white scaling, peripheral or patchy distribution of the blood vessel. Now, tiny follicular papules, itchy red rash, brown spots, wavy or the broken hairs on the exposed skin are also seen. Single or multiple lesion, circular or ovoid in appearance with patches and plaques are also seen. Sharp margination, raised erythematous scaly edge which may contain vesicle. I have already shown you the slides of that. The degree of inflammation is variable. Lesions advance centrifugally from a core with central clearing area appears as a ring. The second part of the diagnosis is wet mount preparation. To confirm, scrap some surface skin materials like scales and put it onto a glass slide and examine them under a microscope to see the hyphae. Third is potassium hydroxide preparation. Skin scraping taken from the scaly lesion edge are placed on a glass slide, and just we do add 10 to 20% potassium hydroxide or QH solution is as it dissolves keratin on the skin scraping, leave the fungal elements such as the hyphae, septate or the yeast cell viewable away from the keratin embedment. Gentle heating also dissolve the keratin and add cover slip. Place the slide under light microscope and examine for the fungal spores, hyphae, and pseudohyphae reflectively seen. Septate and branching, long, narrow hyphae without constrictions are the characteristic of this Tinea corporis. Here one can see the glass slide, and to prepare a wet mount slide, put water on that sample and see under the microscope. And here one can see the fungus in the wet mount microscopy, and one can see the fungal spore and some hyphae also in the microscope. Or there is dermatophytes, ringworm fungi with branching hyphae, and that is seen under the KOH preparation of the skin scale when we put the potassium hydroxide that dissolves the keratin, and one can see the dermatophytes clearly under the microscope. Again, one can see this budding yeast and pseudohyphae also under the potassium hydroxide preparation. Here, 15% cases gave the false negative results, so we are going to have the fungus culture in those cases. In fungus culture, as the fungus grew very slowly, culture results appear positive after many days, and we put the culture on several dextrose agar. It provides identification of the causative organism, and identification is done by examining the morphology of the microconidia, macroconidia, pigmentation, and the surface topography of the culture, that is the surface nature of the culture. Sample is taken from a solitary patch, asymmetrical rash, and entire skin surface, including scalp and nails, can be used for the fungus culture. And here one can see the fungus after it do appear like this. We can just examine it by microscopy to see the fungus, what it is, whether trichophyton, whether microsporum or other. And here is the macroscopy of the culture plates, so that we can have the certain feature on macroscopy also to confirm our diagnosis. And the sample is being taken from the different sites and from the different infection of the dermatophyte. Now, the last is skin biopsy. It is done if other ways fail to see the characteristic. We do have the characteristic histology features, especially required for the Majocchi's granuloma. Histology of the Tinea corporis shows foci of parakeratosis with epidermal acanthoses, spongioses, collection of the neutrophils in the upper layers of the epidermis. The dermis display edema and predominantly chronic inflammatory changes that can be seen in the skin biopsy. So here one can appreciate the compact hyperkeratosis, and there are cross-section of the hyphae seen also, and there are the neutrophils and the sparse lymphocytes in the dermal layer and the neutrophils in the epidermis layer. So that is the histology of tinea. It is really beautiful, created by some very skillful gardener. One can't believe that these are the man-made things and a human skill. It is wonderful and really need appreciation. Now, the differential diagnosis of the disease that mimic appearance of the Tinea corporis with annular lesion, these are discoid eczema, psoriasis, pityriasis, rosy herald patch, seborrheic dermatitis, nummular eczema, erythema annulare, centrifugum, and tinea versicolor. So here one can see the discoid eczema looking like the ringworm. Then psoriasis can give you sometime the appearance of ringworm, and here pityriasis rosea also gave the appearance like that. Seborrheic dermatitis, as one can appreciate, it's also nummular eczema that is also giving the ring-like appearance, and erythema annulare centrifugum, as one can appreciate the ring-shape appearance of these lesions. Now, continuing differential diagnosis, cutaneous candidiasis, subacute cutaneous lupus erythematosus, contact dermatitis, atopic dermatitis, secondary syphilis, mycosis fungoides, and parapsoriasis. So here one can see the tinea versicolor and cutaneous candidiasis gives you, then contact dermatitis gives you the lesion-like tinea, and atopic dermatitis also, then secondary syphilis on the hands, and that is mycosis fungoides that give the appearance of Tinea corporis rash. Now, coming to the treatment, treatment is of three types. Number one, general measure. Number two, topical treatment. And number three, oral or systemic treatment. First, we are going to have about general measures. Skin is kept clean and dried thoroughly. Use the loose-fitting light clothing in hot, humid climate. Avoid the close contact with infected individuals and sharing of their fomites. Examination of household members and pets for source of infection, and treatment of all reduces risk of reinfection. Number two is the topical treatment. This is preferable treatment because of less potential side effects. The topical things, creams, gels, etc., are applied to the lesion and 2.5 centimeter border of the normal skin as creams, lotion, gel, or shampoos. Start with over-the-counter options and apply to the lesion 2 times a day for at least 3 weeks and continue for 1 to 2 weeks to ensure the complete eradication as the recurrence is common. When you see that lesion has healed, you still continue for 1 more week for the complete eradication of the problem. Clot, clot, clotrimazole, clotrimazole 1% cream ointment solution applied topically twice daily. Ketoconazole 2% cream, shampoo, gel, or foam is applied once daily. As one can see, the clotrimazole cream 1% and ketoconazole cream 2% and miconazole cream as 2% is also applied, and naphthene hydrochloride as 1% is also applied as the part of the topical treatment. Now, miconazole 2% cream, ointment, solution, lotion or powder applied twice daily. I have shown you the slide. Naphthene 1% cream applied once daily, or 1 or 2% gel twice daily. Terbinafine 1% cream, gel, spray, solution applied once or twice daily. Older topical fungicidal ammoniated mercury ointment was used in the past. 3% salicylic acid and sulfuric acid was also used in the past. Tincture of iodine for several weeks was also used in the past. But in bacterial superinfection, one can use preferably iconazole or cyclopyrox. Topical steroid plus an antifungal give greater cure rate as compared to the antifungal cream alone, because there is inflammation that also subsides with that steroid. So here is terbinafine hydrochloride cream, and here is econazole nitrate and cyclopyroxolamine cream, and in the past tincture iodine 2% was also being used. The third treatment part is oral or systemic therapy. That is used only when there is lack of response to the topical treatment for extensive or difficult cases with secondary infection, coexistent tinea capitis, or in immunocompromised patient. That is the choice for oral systemic therapy. For also for hair bearing site involving the hair follicles, Majocchi's granuloma, and Tinea imbricata, for chronic dry lesion due to the Tinea rubrum, that is being the preferred choice for oral systemic therapy. In past, glycofulvin and ketoconazole were used, but nowadays, as glycofulvin resistance has been seen up to 33%, and ketoconazole use is limited by its severe side effects or liver toxicity and drug-drug interaction with many drugs as the patient is using. So ketoconazole already is not a preferred treatment. Itraconazole and terbinafine are safe and preferred first-line oral treatment. So here one can see the glycofulvin and ketoconazole. These were the drugs of the past, now not being used and discontinued. And continuing oral systemic therapy, itraconazole 100 milligram once a day for 2 weeks or 200 milligram once a day for 1 week. Give with food, preferably, that gives very good results. Terbinafine 250 milligram tablet orally once a day for 2 weeks, also an alternate treatment. Then fluconazole 150 to 200 milligram once weekly or 50 to 100 milligram per day for 2 to 4 weeks is also an alternate treatment. Now, treatment for the Tinea Corporis gladiatorum, that is seen in infected wrestler and teammates. So, infected wrestler and teammates may be treated with oral itraconazole or fluconazole. Athlete must be removed from the competition or lesion must be covered. And in epidemic cases, wrestling equipment should also be clean. So here one can see the itraconazole capsule 200 milligram and terbinafine tablet 250 milligram and fluconazole capsule 150 milligram. These are the oral treatment given for the selected cases. Now, the prevention of the disease. Ringworm is difficult to prevent, so one should do the measures which are educate yourself and others, be aware of the risk of the ringworm from infected people or the pets. Keep, second point is, keep clean, wash hands, keep shared areas clean in schools, child care centers, gyms and the locker rooms. In contact sports, shower after the practice and after every match. Third is, stay cool and dry. Do not wear thick clothing for long periods of time in warm, humid weather and avoid the excessive sweating. The next point is, avoid the infected animals. The infection looks like a patch of skin where the fur is missing in the animals. And do not share the personal items, others like clothing, towels, hairbrushes, sports gear, and the personal items which are infected by the Tinea corporis. So here one can have the proper measure, just keep yourself, do not walk barefooted, keep yourself washing and bathing after the sports, just keep away from the pets and do not take the towels and the other belonging of the person who is already infected with tinea. So avoid all these things and just wear the clothing which are not very thick enough to just give you the proper aeration. Now, the prognosis is fungus can easily be treated and prevented in the individuals with a healthy immune system, and with appropriate treatment, Tinea corporis can be cured properly. Recurrence or reinfection occur if treatment has stopped too soon or the source of infection has not been identified and treated. So that is the end of the lecture, and I have given the comprehensive account on the topic, and I hope so. If you like so, please subscribe my channel and share the lecture with others. If you have any question, you are just free to talk to me and have any suggestion. That will be welcome. Thank you.